Welcome everyone, and good afternoon to this Healthwatch Northumberland Annual General Meeting and Annual Review. Many thanks for those of you who have joined us, wherever you may be and whoever you may be. I gather there are up to 100 people who will be joining this event, which is very reassuring. And a particularly warm welcome, apart from everyone else, to Alistair Blair and Judith Stonebridge, both very busy people working for the Northumbria Healthcare Trust, and they will be joining us after our break. Now, as you can imagine, this event will be very different to last year's session, which was held in Blythe. But I trust that, as with last year, you will find it interesting, informative and useful. But also, as you can imagine, this will be technically challenging because it's a very different way of doing things. It's certainly very different to someone like myself who is technologically challenged, as people in Healthwatch know, and I'm sure they're smiling right now. But this is being done, as you will see, by Teams, and Teams is a very appropriate word. And I'd just like to pay tribute to Claire from Healthwatch, who has put all this together, ably supported by her colleagues from Healthwatch, Emma, Carolyn and Laura. And I'm sure the technological challenges will have been mastered and we will have a splendid couple of hours. What we are doing today, the agenda is very straightforward. We will begin in a minute or two with the formality of the annual general meeting, and then we will have the review of the year presented by Derry, Healthwatch's project coordinator, and she'll be talking very much along the lines of this annual report, which is a bit vague, but it does say at the bottom, guided by you, which is what Healthwatch is all about. So when Derry has completed her session, we'll have a short break, and then afterwards the presentations on digital transformation in health services by Alistair and Judith, and we look forward to that with great interest. There'll be a couple of occasions during the afternoon when those people watching and being involved can ask questions, and I gather that if you look to the right hand side of your screen, there should be a menu bar with two square speech bubbles, and that's the means whereby you can ask questions, of the minutes, the review, and indeed the presentations. And should anyone wish to have any questions posed after the event, then please email Derry and her colleagues at Healthwatch Northumberland, and we guarantee a response within 7 days. So any questions after the meeting by the end of this month, if you don't mind. So without further ado, if we can move into the annual meeting itself. The report was published, as I showed you before, the report was published in June, and I'm sure many of you will have read that with interest. And for the actual minutes, if we can move on to that one, the minutes of the AGM, they were published ages ago from the meeting held on October the 16th last year. They've been published on the Healthwatch Northumberland website, and I think also people could access them via the invitation link to this particular event. So we need to consider those minutes, accuracy, omissions and so on, and any matters arising. And if you don't mind, we'll leave any such questions for a minute or two, and then Derry Nugent can handle those. And again, if there are any issues emerging after the event about these minutes or matters arising, please contact us and we will respond. And a bit of background to the actual membership of the board, the Healthwatch Northumberland board. We have several members shown there. 4 of them are nominated members, and they represent community and voluntary organisations within the county. The other ones are independent board members, and they express an interest and they join the board and act as voice of the community. And we also have one other member who is on the board, who attends the board from the County Council, which is right and proper. And I'd like to thank at this time all those board members for their continued support, their efforts during the year. You know, it's tremendous for Derry and myself and the team to know we have people of that calibre working with us. And on the subject of board members, we do in fact have a vacancy at the moment. So if anyone would be interested in joining the team and supporting health and social care within the county, then contact myself or Derry Nugent, and we will be delighted to provide you with any information. We have a couple of new board members in that context during the year. Sue Taylor and Mike Allport, you can see there on the screen. They're both independent members, and they brought a lot of experience and expertise in areas such as young people, rurality, mental health, visual impairment, and so on. So thanks, Sue, thanks, Mike, for joining us this year. And I know you've settled in and you're doing a great job. But as we have new members, we also need to say thank you to board members who have left, and Harry Wilson and Kelvin Rushworth, again, like Sue and Mike, representing the north of the county, and they did a lot of sterling work, patient involvement, rurality, and mental health. But also to a member of staff, Leslie Tweddle, who left a couple of months ago, and she was instrumental in getting Enter and View going for the Northumbria Healthwatch, and also in engagement. And she's left us, and she's now working with children, which is a wonderful, wonderful thing to do. So thanks, Harry, thanks, Kelvin, and thanks, Leslie, and best wishes for your future. And also this juncture to say thank you to the volunteers for Healthwatch Northumberland. They provide invaluable support, whether it be in the office or in the general areas of engagement and communication in various forms, various guises throughout the county. And they do bring a different perspective to the independent voice of this organisation. So we thank them as well for their services. So we can now move on, as I mentioned before, to the questions which may or may not have been submitted about the minutes from 1 year ago. So at this juncture, I'll hand over to Derry, who will take any questions, answer them, and remember any after the meeting, please send them in. And once Derry has completed this particular section, she shall move into her own video presentation, which summarises the annual review of the last year. Thank you, Derry.
Thank you, David. I'm pleased to say that we have no questions submitted in advance of the meeting. But if anyone would like to ask a question now, then please use the live Q&A, as David explained earlier. I understand there aren't any at the moment, but what I will say is that if you don't get to raise them this afternoon and something occurs to you, then with all questions, whether it's on the minutes or on the presentations, then you can submit a question by the 30th of October, and we will get a response to you after, and we'll publish answers to all the questions that we are asked today. So we will now pass over to talk about the annual review and the work that we've been doing in the last year. I hope you enjoy it, and I look forward to your questions.
Hello, I'm Derry Nugent, Project Coordinator at Healthwatch Northumberland. I'm going to talk a bit about the work we've done in 2019 and also our plans for the future. If you want the detail of all the work we've done and how people have come together to make changes in services in Northumberland, then please do go and have a look at our annual review. It's full of all the detail you could possibly want. Some of the highlights you'll find in there are about the audiology services and about the physiotherapy services. Two services which are vital to people's health and well-being, and where we've helped people make a real impact this year. However, Healthwatch Northumberland is only as good as the people it can hear from. And two pieces of work that we're very proud of this year are the Your Voices Fund and a report into the county's patient participation groups, which work with and in the county's GP practices. Both of these pieces of work will ensure that we hear from more people across the county. However, one of the best ways that you can get in contact with Healthwatch Northumberland and tell us your views and your experiences is through our annual survey. And I'm really pleased that this year over 800 people gave us their responses. So what did Northumberland say? Mental health services again came top of the league for the things that people wanted to talk to us about. They are concerned about wait times and how to navigate all the different ways into services. I'm really pleased that we published a separate report about mental health services and the findings from the annual survey, and we've had a very good response from the Northumberland Clinical Commissioning Group, which really sets out the position with mental health services. Again, I would encourage you to read that, have a look at it and give us your feedback about what has been said. GPs were also mentioned, as were home care services, and what happened overall is all of those 800 responses have helped to set our priorities for 2020. Mental health services will of course remain a priority for us in 2020. This is not only on the work that came out of the annual survey, but also the work we did on the NHS long-term plan. I'm very pleased to say that a recovery college looks like it's underway in Northumberland, and I hope to report more on that next year. The impact of COVID on patient and service user experience is of course a major piece of work, and we can't ignore it. We've already heard about diabetes services, maternity services and care homes. We will also be prioritising those localities and those places that we hear from less often. Also on our radar this year are digital transformation and services adjusting to the new realities of a post-COVID world. Our plans for 2020 will of course look a little different, and how we work will definitely change. As you will probably already be aware, we have instigated some online forums where every few weeks you can come and talk to us about a particular issue or particular experience that you've had. We do like to have different themes, and if you've got one that you'd like us to talk about, then please get in touch and we'll see what we can do. We're also looking for people to be our community eyes and ears. This is a way that you could volunteer with Healthwatch Northumberland from the comfort of your own home and your own community. Are you the type of person that people tell things to, or gather information about your local area that could help Healthwatch Northumberland make services better in the future? We're also starting a telephone text and callback service. This is for people who maybe don't want to come online with us, or just find it easier to pick up a phone and we can phone you back. Look out for details. It's going to be a really good way of getting in touch with Healthwatch Northumberland. We can't get out and about at the moment, but we will do as soon as we can. Thank you.
Same old problem, forgetting to unmute. Thank you to everyone who got in contact, filled in the survey, talked to us at events, and we hope that you can see where your experience has made a difference this year. It's so important that we and you continue to share what is happening. You don't have to wait for our annual report every year, but there are always our quarterly reports and newsletters to let you know what is happening. If you would like to get copies of those, then please get in touch and we can add you to the mailing list. In terms of our annual report, the things that you would have seen in there as well is a reminder that we are a service contracted by Northumberland County Council, and we thank them for their continued support and the value that they place on having a well-supported Healthwatch. Our formal financial reporting is through our host organisation, Adapt North East, And once again, it has shown what a good fit Healthwatch is with its mission in terms of inclusivity for all members of the community. You will see that all of our income is from the local authority. We do sometimes pick up a few smaller contracts for doing work with Healthwatch England or other health watches, but this year it has been the local authority that has been our main supporter, and you can see that the vast majority of our expenditure is in operations. So what do we plan to do next? We will do what we have been doing. We continue to work, we continue to listen, and that's what we've been doing over the year, and especially during the lockdown period. We'll be focusing on core activities of engagement, communication, volunteering, and having a strategic influence on the health and social commissioners and providers in the county. In terms of engagement, we will get out and about again when we can. And I know this is a question that a lot of you will have. But because we use other people's spaces, we have to be sure that they and we are happy to do so. But if you are a community group with space and can bring people to it, then please do get in touch, and as soon as we can, we will come and meet you. And of course, we're always happy to meet you online as well. The board has set meeting people in non-digital formats as a key performance indicator for us this year. We are starting with the call and text and ringback service, but there should be others, and if you have an idea of how we can do that, then please let us know. Communications, we are also using non-digital communications. You will see regular updates in various county newspapers each month. We want to get out our newsletters to more homes. It's full of the latest news and useful information. If you could deliver a few in your area, then let us know. And I can recommend it as an activity. I spent a lovely afternoon in Holywell down from Seaton Delaval recently, and it was great to be on the doorsteps chatting to people when I was delivering the newsletters. Volunteering, we are keen to keep in touch with more people, and we need more people to get involved. We have various roles from research to engagement to office support. There will be something for you. In terms of strategic influence, there is no point in gathering all this information unless it is used to influence change. We have published several reports this year and have received responses from health trusts, the council and the clinical commissioning group. We value and thank them for engaging with us and maintaining a healthy, challenging relationship. Finally, the areas we want to hear about. Care homes, how they are enabling residents and relatives to keep in touch, is a big issue nationally, but very important in Northumberland at the moment. We're holding an online forum in November, or you can write to us to share your experience. We want to know how creative care homes are being in terms of keeping you in touch with your loved one. Service changes. As we will shortly hear, COVID has brought immense change to health services. We want to know what that has meant for you. With that in mind, does anyone have any questions flowing from the review of the year? We have had a number in advance and they will be published along with any we get to today. The first question that we had submitted in advance is from a lady who is a carer for her husband and feels that the service that she received from the North East Ambulance Service and the information she got from paramedics was not helpful and was not right for their circumstances. This question, you can see it on the screen now, but obviously it will be published along with all the other questions. But we were lucky that we got this in advance and we were able to get a very fulsome and transparent response from the North East Ambulance Service, which will also come up on the screen now. Again, we thank the North East Ambulance Service for their response, and as you can see, it does address each of the issues, and when we send out the other questions we get, we hope that we will get the same responses from commissioners and providers, so no pressure to those who are listening today. In terms of other questions that we've had submitted about the annual review, this one we haven't got a response to, but we will be submitting this to the Newcastle Hospitals Trust. Again, it is a very real issue about access to services, and it's got a COVID element to it. So what is the service for women, older women, to get mammograms? When will they be back in the system? We hope to have a response from North East Ambulance, from Newcastle Hospitals, and we will publish that as well. So they're the questions we had in advance. I can see that we've had several coming in from people who are watching, and I thank you for that. So the first question that has come in is, where would I find more details about the Healthwatch vacancy? Is there an HTL link that we can share? There is indeed. If you're talking about the board membership, yes, there will be. We will publish all of that after the event. So we'll make sure that links to that are available. But also, if you email us directly, info@Healthwatch Northumberland, we can get it directly to you as well. I think that's all the questions that we've got. Are there any other questions? Right, we've got no further questions on that. So I hope you enjoy our annual review, and if there's, as you say, if you've got any more questions, then you've got to the 30th of October. What we're going to do now is take a short 5-minute break. Get a chance to get away from your screen, maybe think of some more questions, come back, and then we will have our guest speakers. So I hope you enjoy it. Thank you.
You're on mute, Derry.
Seriously, the mute thing is going to be an issue. Thank you, everyone. I'm sorry about that. The mute issue is going to continue, isn't it? I'm glad to say that you've taken the opportunity of the break to raise some questions, and we've had a question submitted by Sean Fahy, which says about the Look North feature recently about designated care homes, dementia spaces, and do we have a view about that? I will say that obviously the decision about those designated dementia care facilities is obviously a clinical and policy decision, and like with everything with Healthwatch, we don't have a view in advance of the patient and carer experience. Obviously it is a development and a response to circumstances and what has happened previously in the earlier lockdown, but this is why we're very keen to hear from carers, from people in care homes and different places, to actually find out what it means. So we're very, I think in answer to your question, Sean, we are very interested and as ever taking a watching brief. Don't think we've got any more questions at the moment, so in which case we will go. Oh, there is one more question, I'm being told in my ear. As everyone can see, we've had a question from Gordon Allen. Are there any CCG's clinical commissioning group plans to communicate the PCN, the primary care network plan, to the wider patient community? So as we see immediately, there's a lot of acronyms and a lot of initials going on in the healthcare world. I think that's a really good question. Thank you for that, Gordon. As you know, it is an issue that we are always keen on, about how issues, changes, developments are communicated to the wider service user group. So we will put that question to the clinical commissioning group and publish the answer. So thank you for that. In which case I will now pass you over to David to introduce our guest speakers.
Thank you, Derry. And if I could just conclude the AGM in a sense, because members of the public have had ample opportunity over many months now to read the minutes and to ask questions, and also indeed during this actual meeting to pose questions of Derry. So since those opportunities have been available, I think that's not me. I think I can now take it that we can approve the minutes of the AGM from 1 year ago. Right, having concluded that, we can now move on to the second half of the event, which is the presentations. And as Derry mentioned before, Healthwatch Northumberland itself has had to adapt during the pandemic, but that is small fry, very, very small fry, compared to society as a whole, and especially to the health and social care supporters, workers, professionals within the county. It's a very, very topical issue. So without further ado, I'd like to hand over to Judith Stonebridge. Welcome, Judith, and thanks for giving the time. Judith is a consultant in public health of the Northumbria Healthcare NHS Foundation Trust. So she's well versed in all things healthcare, and she will give us the first part of the presentation on this very topical issue of digital transformation within the health services. There has been very rapid change necessitated by the pandemic, as we know, but I do understand that lessons are being learned by the professionals to sift out from those changes any long-term developments which could benefit the care they provide and the patients they serve. So to hear about what they're thinking about, what they're planning to do, and how they can make it better, which will affect us all, I have great pleasure in introducing Judith Stonebridge. Thank you, Judith, and over to you.
thank you for that introduction. And yes, I'm just going to spend the next 15 minutes saying a little bit about what we're doing, particularly in outpatients, to offer appointments to patients. And I just want to place it in the context of actually this was something we were thinking about anyway before COVID came along. So I'm going to say a little bit about that. But as you rightly say, COVID had a significant impact on that, and there's surely some lessons we can learn. But our reason really is about how do we still ensure quality and make sure that we're maintaining an access for everyone in our local populations. So if I could have the first slide, please. So this just shows a report that was done in 2018, and it was a survey with physicians across the country about outpatients and about their views. And at that time, 25% of doctors were actually already saying that they thought at least 10 to 20% of their patients didn't actually need to travel into a clinic to be seen. And they also, 57% of clinics at that time across the country were found to be finishing late. So that's a significant impact on people's time. 35% of outpatient clinics provide an alternative face-to-face follow-up appointment. So at that point, 35% of services were offering appointments other than actually having to come in face-to-face. And 28% of doctors say that 10 to 20% of follow-up patients could have actually been seen using an alternative method. So back in 2018, doctors were already saying actually there probably are alternatives to this. Next slide. And we are required to do this. So the NHS long-term plan had already set us a challenge to commit to reducing face-to-face appointments by up to a third over the next 5 years. We know this could save money, but more importantly, it can actually save patients time and money, and I'm going to say a little bit about that in a minute. It can also reduce pollution from road travel. There's lots now about how we can do that and allow staff to work in more efficient and satisfying ways as well. So we'd already been given this challenge as an NHS provider to start looking at our outpatient offer. Next slide. And just to put into context what that means for Northumbria Healthcare, so this is our activity data for 2018 and 19, and as you can see on the top left there, 340,000 outpatients appointments are undertaken by Northumbria Healthcare Trust every single year. And if you put that into comparison to visits to A&E, they're 217,700. So it's a significantly large part of our business. So a big impact on our assets, but also on people's lives in terms of having to attend outpatient appointments. So to get this right and have a quality service can have a huge impact. Next slide. We'd done some engagement because we'd been set this challenge to change outpatients, and we wanted to make sure that we did it right and that we did it in collaboration with our local communities. So before Christmas, we did some engagement work with people and ran that through to December and January. We surveyed 100 patients. 45% of them at Northumbria said they travelled more than 20 minutes each way. 79% said they had to allow 2 hours to attend an appointment, so to allow for parking, make sure they weren't late. 50% were accompanied by a family member or friend, and again that might be somebody having to take time off work to get them there. But 49% said actually once they were in their appointment, for all they had a great positive experience, they probably spent less than 10 minutes with the clinician. So that's a lot of people's time being taken up to attend a relatively small appointment. And 41% of people, so this is pre-COVID, were actually saying they'd be quite amenable to having non-face-to-face appointments if it was preferable to their condition. Next slide. We asked people about what would make virtual appointments easier, because I think there are always concerns about that, and we did think, well, people might not come, how can we make it easy? There were people who'd already experienced non-face-to-face appointments, said they'd done it before, it was great. People alluding to the impact on their family, and actually that might be better because their family didn't have to travel. But clear messages about actually if it was appropriate, I think it would be great and it would lessen the burden. But then some people who clearly said, actually, for me, I'd prefer to wait as long as necessary because I want to see the doctor face to face. So a bit of a mixed bag there pre-COVID, but people clearly saying they could see the benefits and it was something they'll consider if it was the right thing for them. Next slide. We also looked at some of the data around, well, actually, who is it that's not coming to their appointments? Because we often look at DNAs or do not attends and think, actually, they're wasted appointments, and they are. But there's a lot of information behind that, because when people don't come to appointments, it means that they're not getting healthcare that they often do need. So we wanted to try and understand that from a health inequalities point of view. And what this slide shows is that pre-COVID, people from the most deprived groups, so that's the bar on the left, decile 1, those are people who are the most deprived communities. their DNA rate for appointments was 10%, compared to if we look at the bar on the other side, which is group 10, which are the people who are most affluent, their rate of non-attendance was only 4%. So that shows that people from the poorest backgrounds pre-COVID were more than twice as likely not to come to an appointment. And we also know that those people often have the greatest burden of disease. So by not coming to an appointment, the health actually might suffer even more. But also financially, if we think about all the things we talked about having to get a bus or park a car and things, it's a great burden on them as well to come to appointments. So thinking about different alternatives can actually help address health inequalities. Next slide. So we embarked in about January. We'd said, actually, as a trust, we're really going to start to modernise our outpatient offer. Based on what we'd already learned, we wanted to modernise the service, but we were really clear that it should be about quality. It isn't just about doing things differently. We wanted our offer to be timely and responsive. Importantly, we want to improve the patient, relative and staff experience, but also it was so important that we improve health outcomes, because that's what the NHS is about. It's about improving health outcomes. Next slide. And then along came COVID. So we had started on this journey, we'd given a commitment, and then COVID came along and things changed dramatically, as I think we've all experienced. So I want to just say a little bit about that and how that's affected our plans. Next slide. So this slide, it looks complicated, but I'll explain it. This is looking at what happened to our outpatient appointments pre and post COVID. So the pink line down the middle is when the government locked us down, and that was when they said everybody had to be locked down, people couldn't go out, lots of information for shielders. The NHS had to focus on treating people with COVID and stop essential business and things like that. So the dark blue line at the top is all of the appointments that we were offering. So they were all of our offered outpatient appointments. So fairly static, some little ups and downs there, but generally we were running on a pretty even keel of about 8,000 to 9,000 appointments a week pre-COVID. And then just before the official lockdown, you can see that those appointments dropped. So we were starting to get messages that we needed to stop our activity a little bit, and things were starting to change. The green line is the face-to-face appointments. So they were people that were coming for face-to-face appointments. So you can see pre-COVID that actually most appointments at that time were face-to-face, but a significant drop off even before we were locked down. So people were we were saying, actually, we're not going to bring it in for those face-to-face appointments. Lots of people were cancelling, and we knew that that probably wasn't the right thing to do. And the reverse of that is the pale blue line at the bottom, which is our virtual appointments. So again, we weren't doing very many of those pre-COVID, but as lockdown came, we suddenly stepped that up. You can see that increased, and then as we move through COVID, so this is up until the end of June, we're just looking at the last lot of data now, haven't got that today. You can see there was a bit more of a leveling off, so we've started to increase more appointments, and that's continued to increase, but a sort of maintain that offer of non-face-to-face, but still some face-to-face for people who need it. Next slide. But our objectives were still exactly the same. So we had to do this major service change overnight that nobody would ever want to have done, would never want to completely switch off a service and set up another one overnight, but we were forced to, because we had to protect the health of the public around COVID, and people were worried, and rightly so, people didn't want to come out. But we still felt that our objectives were about modernising the service, being timely and responsive, making sure we did what patients wanted, and improving health outcomes. And as we've travelled over the last few months and weeks, we've tried to learn from that, and that is our vision going forward. Next slide. So we've developed a quality assurance framework so that we can make sure that as we move forward, we don't want to tip back to bringing everybody back in face-to-face, because that's not right, and we know that there's waste that we can avoid. It's not helpful for patients to do that. But we wanted to make sure that what we do is the right thing, and that when we offer non-face-to-face appointments, that they're clinically appropriate and that they meet the needs of the individual patients. So within that feedback, we're looking at performance and activity. How many appointments are we offering? How long are people having to wait? But also, what are the public and patients saying about that? What are their views, and what are our staff saying? And what is the access and uptake? What are we doing about health inequalities, and are we communicating effectively? So we are really measuring ourselves very hard against this. Next slide. This is a miles less travelled slide. So we said a little bit about wasted journeys and things. And this is a slide that we've just pulled together, which looks at activity from April to September. And in the bottom right there, you can see that as a result of us converting appointments from face-to-face to non-face-to-face, just in that period of time, we've saved over 1 million miles less travelled as a result. And you can see the average miles travelled to appointments this year is 8.4 compared to 16.8 last year. So significant changes in what we've done, and changes in the numbers of appointments. And as you can see, about 51% of appointments were non-face-to-face this year compared to 7% last year. So huge differences that we've made there, and we'll continue to monitor that monthly. And of course, for every mile saved, we're saving the environment, but we're also saving costs to petrol and parking and things. Next slide. This slide just shows did not attend rates. So remember, we had that slide about deprivation. This shows did not attend rates by face-to-face and non-face-to-face appointments. So we can see before COVID, so again the lockdown line is in pink, and before COVID we sort of ran on a did not attend rate bobbing around about between 10 and 6%, I would say. Then as lockdown came, we saw quite an increase in did not attend in that dark blue line. And that sort of settled down to around about 8% at the end of June, so probably slightly lower than it was pre-COVID, but within the margins of what it was before. The green line shows the did not attend for face-to-face appointments, so you can see people were worried about coming out. A lot of people weren't coming to their appointments round about lockdown, and actually that stayed and sort of levelled off at around about 11% even since COVID. Whereas the not attends for the virtual appointments and for the non-face-to-face has sort of seems to be settling at around about 5%. So for me that's quite interesting, and it's looking like actually the non-face-to-face are not creating a lot of people not attending for their appointments, which is reassuring. But we need to look at that more deeply. We've done some of that work. It doesn't seem to be negatively impacting on age. We've looked at age across all of this. We've looked at rurality, and it doesn't seem to be negatively impacting on any of that either. Next slide. We've also done a lot of patient experience work from our patient experience team, and again this shows for our last quarter that patient satisfaction with services remains high. So about 96% of patients are still saying that they're getting their needs met in clinic, that they're getting their questions answered, they're feeling like the consultation was appropriate, and these are people who are purely accessing video appointments, so that's really good. That's in line with what we were seeing before we moved to virtual appointments. I will say the response rate of these surveys isn't great, so we are trying to encourage better uptake so that we won't be assured with the data we're getting. Next slide. This was some engagement work that was done independently on the local population of Northumberland and North Tyneside, asking people, and it was during COVID actually, how they'd like to get appointments and what would they like to do online. And again, we can see, you know, a significant proportion of the population are keen to use online things, whether it's about requesting a sick note or a video consultation or a repeat prescription. But again, that depends on the condition and it depends on what you're going for. Next slide. So the feedback from, we got some information actually from Healthwatch and from PALS, our Patient Advice Liaison Service, looked at what they had from the public and from the population over the last couple of years, because we wanted to look at that as well. And that was clearly telling us that the themes pre and post COVID are actually very similar. So concerns about delays in waiting times, processes, issues, support for virtual consultation seemed good. Some people were saying that was very positive, but a real acknowledgement that one size doesn't fit all, and it has to be if it's appropriate to that individual. And similarly, our staff are saying there are some key benefits for patients that can really see the value of that. From a health professional point of view, it doesn't actually save any time because you still have to do the appointment, you still need a room to do it in. But again, an acknowledgement from them that one size doesn't fit all, and we need to make sure that things are clinically appropriate and that people are able to access their appointments. Next slide, I'm nearly finished. So in terms of next steps, there's a lot of work going on in the trust. We're working with primary care, we're working with people like Healthwatch and other people to get the views from the public. It'd be great to get some views today. So our priorities are looking at actually how do we further address the impact of things like digital poverty. So people who don't have access to computers, people who don't have digital literacy, who aren't very familiar with using computers and things. That isn't always the elderly population either, that's across all ages. Or digital connectivity. We obviously live in in a very rural county where there's problems with even just getting broadband. So just started some work with the voluntary community sector, ADAPT in the west and the Glendale Centre in the north, to look at actually how can we have those as hubs where people could potentially access appointments with support to get online, which is a bit of a middle ground to travelling all the way down to a hospital. So we're going to be doing a pilot there to see how that works. We really want to continue engaging with the public, patients and staff, and to understand that we are doing the right thing. Are there any groups that we're missing around this to make sure that we're not knocking off anybody's access? And also to keep reviewing our data that I've shared today, but as well to increase our communications plans so that we're letting people know what is available, what their choices are, and how and where to access services. Last slide. And that's me done. I think there's just the last slide to come up there. Thank you.
Thank you very much, Judith, for that informative and enlightening presentation. You know, it brings home to myself, and I'm sure everyone watching and listening, you know, the enormity and the complexity of what you all do, and the changes and challenges which you are facing, and also, you know, the more detailed information on access, on inequalities and the changes and so on. So thanks very much for that. But if it's okay, Judith, we'll wait until after the next presentation should there be any questions. And just a reminder to people, if you do have a question, please use the little 2-square speech bubble on the right hand side of your screen to pose a question which I'm sure she'll be very happy to answer before very long. So thanks again, Judith. And that moves naturally into the next presentation, which is a live narrative on the theme of digital transformation, but on remote consultation in primary and secondary care. And to make this presentation is Alistair Blair. Now, Alistair is one of the medical directors for the Northumbria NHS Foundation Healthcare Trust, but he's also a practicing GP. So he has that strategic awareness and strategic decision-making responsibility with his colleagues, allied with the pragmatic day-to-day experience of working with patients, you know, in his surgery or elsewhere. So with that sort of breadth of background, Alistair, I welcome you to this Healthwatch event, and we all look forward to your narrative on remote consultation in primary and secondary care. Over to you, Alistair. Thank you.
Thanks very much, David. Just checking people can hear me okay. And what I didn't do is, I think Judith's presentation was excellent, but we thought between us that if I did more of a general talk rather than another presentation, it might just give you two different styles of talking about this whole issue, both around digital and I think remote consultations. We can take the slide down if that helps. I don't mind what format we use. So from a clinical point of view, and the tools that we're using in both primary and secondary care are the same. So the majority of remote consultations are done by telephone. Before COVID, about 1/3 of all primary care consultations were done by telephone across Northumberland. It was higher than most other areas. And obviously COVID came in, and as Judith has said, there was a real appetite before COVID to try and increase the offer of remote consultations, but then COVID came and really massively changed that. You may be aware that NHS England have more or less insisted that it is a remote consultation first model for the whole of primary care in England. So nobody is allowed to just go and book a face-to-face appointment. That's predominantly for infection control reasons around COVID. But even within that, we've still found that the vast majority of consultations are over the telephone to start with. About 1/3 are ending up with a face-to-face appointment, with GP surgeries. And then there are some additional tools. So AccuRx, which works particularly on mobile phones, has certainly become very popular. We're using that in the hospital, and GPs are also using that. And that's got several different things. One is a secure way of sending text messages. So patients are sending their blood pressures into practices, for example, that way. It has an image, a way of transmitting secure images straight into your notes. So people are taking images of rashes or of tonsillitis and other things that can give very, very detailed pictures. And that goes straight into your clinical notes. And then there's Attend Anywhere, which is a computer-based platform, which is mainly used for hospital outpatients. And each of these platforms has got advantages. Some of them have got disadvantages over face-to-face. And certainly in primary care, what we tend to find is if things can be addressed and the problem can be sorted over the phone, it's sorted over the phone. And if it can't be, people are being brought in. I think at the height of COVID, people were feeling that there was a little bit of resistance in some GP surgeries to see people face to face. And I think that's died off latterly as I think people have got more confident with the infection control measures in practices. And there is still a number of people who are still very reluctant to leave their own houses. We still have people presenting, unfortunately, late with quite significant physical problems. Some people not keen to come even for things like flu jabs or bloods, which I do worry about because I think that could penalise their own health. And actually the risks of COVID are probably not nearly as big as the risks of a known health problem that you've got not being adequately monitored. So we need to think about that. And I think what we need to think about with the whole of the remote consultation models is they should all be in addition to face-to-face where face-to-face is needed. One of the things that we have found is that there are quite a lot of advantages, particularly for people who've got working age. People would previously, for an outpatients for orthopedics, have taken often a half day off work, often for a 3 or 5 minute consultation. If they can then get that done over the telephone, such as with the remote fracture clinic, the x-rays in front of the expert on the phone, you can have a very good consultation. That's really good from a time point of view. It helps people who've got caring duties, and it also helps people who've got caring duties for children as well. So there's lots of advantages with that as well, but it's not going to be for everything. I think we need to think about this in terms of several different ways. One is, how do we make sure that continuity is there so that if you need to speak to the same doctor and see them, that's really important. What's the difference between a new problem where the face-to-face and the relationship with your clinician is really important, and follow up and review where you're often sharing information and progress, and actually a lot of that is probably as effectively given over remotely, telephone or otherwise. There are some issues such as the National Talk Scheme, which is really an encouragement for people, not in ambulances, but people who are going to go to major A&E departments themselves to make a call to 111 or similar before they go to the department. Now, that's not fully implemented yet, but there is a national move to that so that people are directed to the right level of care and prioritised straight on. There's also the whole issue around remote consultations in care homes. You'll be aware that the government have issued iPads to all care homes that want them, so that actually people can have a ward round virtually with both a consultant geriatrician or a general practitioner on a regular basis. There's also remote monitoring systems that have gone into quite a lot of care homes, and a lot of this will actually quite transform, I think, the level of care that people are getting. And also when care homes are trying to reduce footfall to reduce COVID, it kind of helps with that. There is also another form of remote consultation that might not be immediately apparent that's really important, that over really, I suppose, since February time, we've had a real revolution of GPs and consultants talking to each other through electronic means about patients. So if GPs have got a query about a patient or a clinical problem, rather than just making a referral and then patients waiting for several months to be seen to then be given an answer for the GP to implement, where it's obvious actually what's happening is they're getting the advice normally within a matter of days, and then able to share that straight to patients. And that's a real game changer. So we're seeing that with gastroenterology, where there's lots of advice coming out. Another example is with dermatology, where often those inquiries are given with rashes, with clinical information, and the dermatologists are coming back with, try this, try that, this is the right sort of tests that you need to be doing. And at the moment, that whole process, if it had been a face-to-face with the dermatologist, it would have been probably about 4 months, and at the moment it's probably happening in about 4 days. So some real changes in terms of things that aren't directly patient-facing that make a massive difference to patients themselves. I am conscious within all this that we need to then also think about the kind of social aspects to medicine, how social isolation and isolation, some people want that kind of face-to-face environment, and actually how also at times I think contact with healthcare professionals also is a way in which people get social contact. I think this is going to be increasingly important as this carries on probably through into the next year. And we also need to look at where things like social prescribing and some of the other initiatives out there can actually look at augmenting and helping those issues of social isolation, so that actually the clinical conversation can be one way, but actually the isolation and the support and the other bits that you need can be actually probably enhanced in other ways. So that I thought was just a real overview of some of the emerging issues and problems and advantages that we've seen. One thing that I thought would be interesting is for you to know that at the moment, as a trust, we're doing about 12 to 13,000 telephone consultations a month and about 1,000 computer consultations a month. So that gives you an idea that this isn't all computer, that most of this is with familiar technologies, because most of us are familiar with telephones. And at the moment, the number of face-to-face is increasing, and I think it will reach a natural equilibrium, as I think it will with primary care as well. But this is a journey that I think we need to go on with our patients, and I think getting that voice from Healthwatch and others is really important, because one of the things that we've found, I think, across the board is it's quite hard to get everybody's opinion at the moment, because we haven't got meetings, we haven't got bits where you can sit down with a group of 20 people and say, what are you feeling about this, other than virtually. And so an environment like this, it is really invaluable for that. So what I hoped we could do is then move on, Chair, if that's okay, to kind of some questions and just pick up some general themes either in the questions and also subsequently from Healthwatch to see if we can really improve the whole offer that we make to patients.
Thank you, Judith and Alistair, for two really thorough and interesting presentations. And I think there was what was very clear from it, for both of them, was the challenges, but also the opportunities that digital transformation provides, both for you as health service providers, but also for us all as patients. We have had some questions, live questions submitted, but I'm going to go first to one that we had submitted prior to the event, which actually also has come up by the same person from Julie from the Northumberland County Blind Association. And I'm pleased that this was submitted by Julie beforehand, because it means we have been able to share it with Judith and Alistair, and they've been able to consider the very real issue about what the implications are for visually impaired people with this move to digital. So I will ask Judith, I think, to answer this question, and Alistair, if there's anything afterwards that you'd like to come in with. So over to you, Judith.
Thank you. Yeah, it's really important question, and I think something that's definitely needs to be considered in all of this, because it isn't just about health inequalities, it's about other inequalities as well. I think, as I said, we had to make a change rapidly overnight, so we didn't have a lot of time to do engagement at that point. That is what we're doing now. Be really keen to work with County Blind Association on that going forward. I think to give some reassurance to what, and building on what Alistair and I have both said, a significant amount of the consultations are by telephone rather than by computer, so I would hope that might help in some way. But as well, we absolutely aren't denying anybody a face-to-face appointment where that is either clinically or personally the most appropriate thing to do. So it's not about saying you absolutely can't have that appointment, and that is so important. But going forward, as I've said, I think we'd be really keen to work on that and to make sure that we're absolutely being as inclusive as we can. And similarly with some of our materials and things, that's something I'd be very keen to pick up after this meeting to take forward and to feedback again on how that's progressing.
I think the only other thing is that
Sorry, Alistair, that's come back to me. Thank you for that, Judith. I'm just going to say to Julie, if there's anything you'd like to do a follow-up, please just put it in the Q&A, but I will pass back to Alistair.
So all I was going to say is all of the pre-existing self-care promotion materials, including those in Braille and other things, are still in existence. So if anything, all we've got is an addition to what was there previously. So nothing has been stopped that was previously there in terms of its accessibility to visual and other groups, talking books, all those other bits. So I think all of the new digital bits is only ever in addition to what was there before. It's not replaced it, and there is no plan to replace what was there previously, because there are people who don't have access to printers. There's a need for Braille, there's a need for talking books. So the way I would try and think about this is these are all in addition to what was there before, rather than in any way replacing them and making them redundant or cease to be existing.
Thank you for that, Alistair. And I think what's really interesting and really pleasing, because it goes to the question that Julie has posed and the issue that she's posed, which is that it would be good to discuss further. And I think that if today is part of facilitating those relationships, those connections, then I think we would be very, very pleased. So thank you for that question, Julie, and thank you for Alistair and Judith for your answer on that one. We have had another question submitted before the event as well, and I think this takes us into another area of digital transformation, where the person who raised this question has experience of having treatment and support within groups, and understands that this can be done virtually, and her question is about how and what is being done to bring this forward in Northumberland. So if I come to you first, Alistair, and then Judith.
I mean, this is a subject that is actually very close to me. I was involved with setting up the group clinics in rheumatology that I think operate particularly from Berwick, where we've done some research evaluation of it. So it is possible. I think that we need to separate out group support, group education, and group consultations, because I think they're going to end up in slightly different places. At present, they're not existing, because I think the technology just hasn't been there for multiple people on secure platforms to get all online at the same time, and that's partly because there are lots of, there are digital platforms, Zoom and all sorts of other things where lots of people are meeting at the same time, but a lot of those don't actually meet the NHS's standard of security, and what we don't want is any confidential information to be breached, which obviously your health records and your healthcare is. I do think that we're going to end up with significant interest for those with long-term conditions for group support and group education, because you can see that the whole digital bits should really add to that, and may well be an offer to those particularly with physical disabilities where travelling to support might be difficult. I think group clinics where it's a one-to-one clinical evaluation of a patient, I think the governance of that's difficult, and there are examples that are working, but I think that will be further down the line. And so what I would say is that actively we're looking at group support, group education, but I think that the idea of group interactions about your individual health with the doctor, I think on a virtual basis that's going to be a little bit harder to do. You've got to be aware of the fact that people can record things. If you're in a room in a group education, it's pretty obvious. If somebody's got a camera out, is absolutely no way of knowing what is being recorded or any of the other bits. So we've got to be really careful about confidentiality and about how we are sensitive to individuals' needs in this. So the governance is really important, but I think the opportunities are great. And I think if we can support people, particularly at the moment where people are not able to mix socially, this has got to be a good thing.
Okay, Judith, would you like to add anything? Okay, in that case, we will go to our live questions, and I think I can see a bit of a theme developing around the issues of inclusivity and especially around the hubs, and as you spoke a bit about those earlier. So Abby Conway from Northumberland CAB has raised a question which you'll see in the Q&A, which talks about increasing digital engagement and capacity building to facilitate digital engagement, especially those most at risk of poor health outcomes. Judith, you said a little bit about that earlier. Is there anything you'd like to add in response to Abby's question?
Yes, I think it's a great question, Abby, and I know that you and I actually spoke about some of this pre-COVID, and you inspired me to think about actually how did people who perhaps were experiencing financial difficulties deal with letters that might come in plain white envelopes, and it might not differentiate between what is from the NHS and what is from elsewhere, and that was really insightful for me. And the plan was then to sort of do some consultation with the people that looked like they weren't coming to appointments, so there were specific groups, age and gender, young working age men from more deprived backgrounds. Unfortunately, COVID kind of put the brakes on that, but we are really keen to do that engagement work to really understand what is it that's preventing access. Some of it will be about digital access, but some of it might not, so really keen to understand the breadth of that. In terms of the issues of digital literacy, digital poverty and digital connectivity, as I mentioned, I think the pilots that we're trying to do with the 2 voluntary community sectors in Northumberland, providers in Northumberland, will give us a richness of learning there, and those providers both also offer digital skills development. So I think it's adding to the value of coming for an outpatient appointment. Actually, if people are wanting to develop their digital skills, they can actually do that in that setting as well, so that longer term, if they wanted to, they could have that appointment at home. They've also agreed to work with us on some of the language and some of the messaging in the content of what we send out, so that feels appropriate and understandable, and that we're removing barriers then. So as I say, we're really keen to do that further engagement going forward, to understand that, and I think keep looking at the data to just make sure that we are improving things and get feedback from people like yourselves and from the wider population on that.
Okay, would you like to add anything, Alistair?
I think Judith covered that as well as I would have. Nothing to add.
Okay, thank you for that then. I think Jane Pennell has also raised a very, very important issue. She's talked about the difficulty of travelling for frail and elderly people, but I think it's the second part of her question that for me and everyone at Healthwatch is about who she calls a silent minority, because they're the people we definitely want to hear from. She talks about younger people might find digital engagement with health services difficult, where home might not be a good place for conversation. And of course, this doesn't just apply to young people. It applies to anyone who is finding home is dangerous and not safe. Obviously, situations around domestic abuse spring to mind immediately. How sensitive and aware are services about those issues that actually home is not always the best answer. And again, how is this going to be addressed? So that's a really good question, Jane. Thank you.
Shall I pick that one up, Joe?
Yes, please, Alistair, if you would.
So I think it's an excellent question. One of the things that I think, and this was framed about younger people, is that there is a higher rate of mobile phone use and ownership amongst probably teenage children upwards. And actually, I think that's probably quite empowering in that most of the contacts, people can take them away from the home environment, and it is easier to get away from that environment with a phone than it is sometimes with a face-to-face appointment, because actually what you're finding is that often a controlling other will always be accompanying somebody when they know they've got an appointment at 2 o'clock on a Thursday. Whereas if you're actually able to make a call, it's sometimes easier to actually make a quick call to a health professional when you know that you're actually going to be independent from a controlling influence and things. So I actually think that provided people always check about this, and most of us are trained to always check, is this a right place, is that, can you talk safely, etc., on the phone or otherwise, then I think there are some advantages. There are visual clues. People will be aware that there are ways in which you can actually signal that you feel that you're being threatened over a video call, which again I think is exactly the same. You can use those same signals in a face-to-face consultation if you're being accompanied by a controlling adult. But I think that some of this might make that easier rather than harder. What I think we just need to be aware of is just, it's almost those people who aren't contacting, and my biggest worry is actually that those people who almost through neglect are not accessing healthcare, and that's the same worry that we have with face-to-face as with digital mechanisms. But I think because of COVID, there may be an inappropriate assumption that people are not coming because of concerns, and that might be because of other safeguarding issues. So I think we need to be aware of all of those issues, but I actually think that provided people are wired up and aware of the issues around safeguarding, which they are, this actually might allow people to break free and get the care that they want in a more confidential manner than they previously had, because it takes some of the control of others out of that system.
Thank you for that, Alistair. I don't think there's anything you want to add, Judith. Are you okay? No, that's fine. In which case, I will go on to the final few questions then. Very good point made by Councillor Susan Dunworth, recognising that the value of virtual consultation, but it is still necessary. There are circumstances where it is still necessary to have a face-to-face consultation. And I think, Alistair, you have said that quite clearly, that it's not a replacement, that it is still going to be an option, and it's not going to be. Can you reassure people today that it's not going to be the poor relation in terms of how people access services?
I can only speak from the trust of my own perspective that I don't think face-to-face being the poor relation, I don't see that ever being the case. That if you need to examine somebody, you can only really examine somebody where there is a need by doing that through physical contact with that person. Now we need to be aware at times, and hopefully we're not going to get to the peak of COVID that we were in April time, where people were very worried about that. But I don't think it would. What I'm more concerned about is people actually thinking that a remote consultation is second class rather than the face-to-face. And actually, I think with the appropriate case selection and the appropriate things, it is absolutely equivalent to a face-to-face consultation. So I'm more worried that people see that they're getting a cheap job by speaking to somebody on the phone, and actually it's often absolutely, as Judith said, it's as time consuming for the clinician, and it can be absolutely as rich an environment in terms of the information and the sharing as face-to-face. So what I would say is that this is a toolbox and you use the right tool for the job. If you need to examine someone physically, you've got to do that as far as I can see physically. But all of them are interchangeable, so I wouldn't say any of them is inferior or superior to the other, to be perfectly honest. I think, and this will be the way that I think we need to view it going forward, is each of them is a toolbox. If somebody texts me a picture that actually says 1,000 words of what their rash is like, that's fantastic and that's really quick, and that's so this is about the right tool for the right job.
Thank you for that, Alistair, and I think that is a reassurance, hopefully, and as we say, obviously that is what Healthwatch is here for. We obviously will want to hear as people's experience goes on, and I think it links very clearly to Margaret's point, where she says, and I think the first point of her question is quite a good one, and you talk about your toolbox as a GP. What about those practices that do not have video links? Is connectivity in GP practices an issue now, or is all service?
Well, firstly, 90% of telephones, and everyone's had telephones, but every practice is wired up for video consultation, and as are our departments where it's needed. So the connectivity from a healthcare end is not. Where I think it's more valid is that some people don't have the technology at their end to do video conferencing, and sometimes video calls that the quality of the image can be quite poor. It's certainly for certain things, actually, it's one of the reasons that texting of photos can actually be a lot more useful, because the resolution of the image is a lot better than some videos. But both in Northumbria Trust and in all practices, the video cameras that are needed are there. There's no practice that doesn't have them.
Okay, that's good to know. We have some more questions, and I think it's quite interesting. One of the issues that's been brought up is about the importance of community transport, which I think answers Jane's point and also links to the whole issue about hubs. And again, that was from Bellevue Paul in Bellevue in Belford. So again, I think, Judith, there's another connection there that might be useful for your work. So I think what we will say at this point is that we have more questions than time, as ever. So we will gather all of those questions together, and everybody that has raised a question and every question that has been asked will be answered. Now, if I have the next slide, that will make that clear for you. Thank you. So if you've any more questions, you can ask us in whatever your preferred format is. And, you know, given that we're talking about digital transformation and the importance of not just relying on digital, if you've got any questions about any aspect of today, but especially about today's presentations, because I think the questions that have come in and been answered and everything that Judith and Alistair have said has really struck a chord with a lot of people. Please do get those questions to us by the 30th of October, and then we will publish the responses afterwards. So can I just say thank you to Judith and Alistair for answering the questions that were put beforehand, and for everything that you will probably be involved in answering the rest of the questions as well. And at this point, I'll hand you back to David.
Thank you, Derry. And again, just to repeat what Derry quite rightly has said, thanks to Alistair and to Judith for their presentations, you know, to share their thinking about what they're planning to do. So we very much appreciate that. And I think the level of questioning, I think, is testament to the interest which people have in what you were doing. So thanks for giving the time and sharing your thoughts with us. And a further reminder about the vacancy within Healthwatch Northumberland. If you are interested, we're a very positive team. We do try our best to make a difference to the wider community, so get in touch with us. And also on the web is a few pen portraits of what the board is, so you can find out what your potential colleagues would be. Anyway, just a few final words from myself. I think what you've heard this afternoon is what Healthwatch is doing and has done, and much more importantly, what the healthcare services are doing, planning, thinking, adapting. They face huge challenges to adapt, to improve, to be more efficient, to be more effective, to keep people safe and well. And of course, particularly challenging during this pandemic. It's been a tough 6 months or so. And I think I sense that a further 6 months, perhaps even longer, of difficult times for us all. So for Judith and for Alistair and their colleagues, we wish them well. And during this time, Healthwatch Northumberland has continued to work with the providers and the commissioners, as Derry has shown in her review, to be the independent voice of the people of Northumberland. And I think, as Judith and Alistair mentioned in their presentations, it's all about, in many ways, communication and engagement, which is the stock in trade for Healthwatch. That's what we do. We listen, we advise, we pass on information, we write reports in every way, shape or form to try and make it better. And I sense, despite these difficult times, that there is a much greater appetite within the health and care services to more robustly, heavily engage and communicate with the wider public, because the voice of the people, what people would like to see and the reasons for it, really influences the actions which the health and care services take. So as these autumnal days are with us and as winter approaches, we shall continue to work in communication and engagement with the staff, mental health, care homes, community nursing, GPs, hospitals, carers in the homes, dentists, ambulances, opticians, a full range of people. They're doing a tremendous job. But let us not also forget the commissioners, the people who work in the county council, and those in public health, who in many ways, unseen, unheard, do so much sterling work to support the frontline services. And also a worthy mention of the voluntary and community sector, again often unseen, unheard, but they do a valuable service in helping individual people through times difficult, uncertain or whatever. All of them, they are well intentioned, they are dedicated, and I think we've seen that with Judith and Alistair. I think it's fair to say that never have so many of us been so well served by so many professionals within Northumberland in the areas of health and social care. And I mean that. And to all of them, from all of us, thank you. To everyone, keep safe, and we look forward to meeting you in person in 2021. And until then, as best we can, keep smiling. Thank you and good afternoon.